Yeah.
Cool.
All right. DataFest 2021. This is math theme. Okay, so our research question is, which factors are significant in predicting illicit prescription medicine use in Canadian young adults? Our response variable is medical and non-medical use, a new binomial variable that we created by grouping all of the prescription non-medical use variables in the last 90 days. Our explanatory variables are demographic information, chronic pain, mental diagnosis, and young adults were defined as respondents under the age of 24.
For our data, we used the original dataset of CA, Canada dataset. The dataset was provided from the Survey of Non-Medical Use of Prescription Drugs program, which employed an online survey of the general adult population to understand non-medical use of prescription drugs. The dataset had 185 variables with 10,007 observations. For the working dataset, we used young.canada, which we limited the age of the respondents to under the age of 24. We also removed redundant, irrelevant, or collineal variables. And there were 39 variables with 729 observations.
Our first model was a binomial model. We started by regressing demographic age onto the non-medical use response, and then we continued adding significant variables until we get the model shown. The final model contained age, mental diagnosis, chronic pain, demographic region, and veteran status. The AIC on the model was 961.13, and the residual deviance was 939.13 on 780 degrees of freedom.
For our second binomial model, we used stepwise model selection. The new model had the AIC of 555.42 and the residual deviance of 531.42 with 621 degrees of freedom. There were 11 explanatory variables, including veteran's status, healthcare profession, income level, THC use, tobacco use, help for substance abuse, chronic pain, opioid prescription for chronic pain treatment, history of ever attempting to get a prescription from a physician for a medication without need but with intention to sell, and medical use. The ANOVA best fit model comparison test showed that there was not much significant difference between the two models, so we could use the lighter model.
When we were looking at how valid our selection variables was for those binomial models, we did some forward and backward stepwise selection. We can see that when basing our decision off of the adjusted R squared, we'd want around 40 variables, CP around 30, and BIC around 8. We found that the 10 most relevant variables according to stepwise selection were the 10 of those included in the binomial model. We also tried to fit a decision tree for the data. We split up our data into an 80% training set and a 20% testing set. And then starting from all of our variables, we narrowed it down to only 4 that were used in the decision tree. And those were the medication use, the DAS summary, information, income, and then the history of trying to get a prescription with intent to sell. And that tree, which had 5 terminal nodes, gave us a training misclassification rate of 26% and a testing misclassification rate of about 35%. After that, we tried to prune the tree, and we found that the 5 terminal nodes from our original tree were as good as it would get, so pruning didn't offer much improvement there.
From all of this analysis, we found that 11 variables were significantly related to the non-medical use of prescription drugs when generating binomial model and running stepwise selection, and those relevant variables are listed here. When creating and pruning the decision tree, we discovered that 5 variables were significant. So our recommendation is that if your goal is simplicity, we recommend that you account for the 5 variables included on the decision tree. However, if your goal is to predict or to have a deeper understanding of the data and relationships of the variables, we recommend that you focus on the binomial model and the 11 associated predictors.